you know, I'm Eric Austin. I work at Vanderbilt with Dr. Hemnes and Lisa Wheeler and with Aaron Garnett. I care for people with pulmonary hypertension who are children and work closely with the pulmonary hypertension group doing research and clinical care of people who have pulmonary hypertension. So we're going to talk in this aspect about the genetics of pulmonary hypertension, as you can see. And Lisa and I had put together a talk that we hope would be helpful for people thinking about pulmonary hypertension in their families and whatnot. So pulmonary arterial hypertension that occurs in families is, by definition, considered to be familial pulmonary arterial hypertension. As you can see, we try to make it a definition dictated by the notion that two or more people have defined pulmonary hypertension in a family. We also know now that there's an entity called heritable pulmonary arterial hypertension, which familial pulmonary hypertension naturally fits right into. So heritable suggests that the disease that an individual has can be transmitted to the next generation of individuals or transmitted down through the family pedigree over time. So now when we think about heritable pulmonary arterial hypertension, we think about two different types, which are both heritable. One is families who have pulmonary hypertension and we don't know why. There are families who have pulmonary hypertension that we don't know a single obvious genetic cause. And then there are families of people who have never had pulmonary hypertension in their family whatsoever, and then an individual develops pulmonary hypertension for the first time in that family, but then we subsequently learn that that person has a genetic variation in a gene that makes them likely to develop the disease or likely to have developed the disease. So let's talk about changes in your genetics a little bit. You guys probably know about DNA. DNA is sort of the building blocks of life, what helps make us who we are. Our DNA is actually something that is largely inherited from our mother and our father that comes together to share genetics from mom and dad to make us who we are. A mutation, as you can see behind me, is a change in your genetic material that has the ability to cause disease, would be sort of a simple way to think about that. Everyone in the population has variations in who we are for multiple reasons, but one of the variations that's important is the fact that we don't all share exactly the same genes. And then sometimes our genes actually change a little bit. So while we may have the same gene, we may have slightly different building block instructions from each gene. So the characteristic of each gene may vary a little bit. And sometimes that variation can be completely not a problem, and sometimes that variation can make us susceptible to develop disease. An individual who carries a mutation but does not have a symptom from that mutation that we know of or a sign of disease, if it's a mutation that causes disease, and not all mutations cause disease by any means, but if you have a mutation that we think should make you have disease but you don't have disease, a simple term for that is carrier. You carry a variation in your DNA, which we would call a mutation, but thankfully you are well. However, even if you are well, you could still pass that mutation on to other people in your family who could develop the disease while you may not. That gets into the term penetrance. Penetrance is a term for saying that you have a variation in your DNA called a mutation that we think could be problematic for you, but it does or does not ever become a disease. So a disease-causing mutation that results in you developing a disease, for example, the BMPR2 gene that we'll talk about in a minute. There are some people who have BMPR2 gene mutations and have disease, pulmonary arterial hypertension. That means that mutation has, in medical terms, been penetrant. It has caused the disease to occur in you. But there are other people who have a mutation, but that mutation never actually results in the detectable nature of a pulmonary arterial hypertension condition. So incomplete penetrance, as you can see on the slide here, is the mutation is present, but the person does not have the disease that the mutation should cause. So Vanderbilt has followed patients and families with pulmonary arterial hypertension for a long time, dating back to Jim Lloyd and John Newman. Jim Lloyd, who's kindly mentored me for many years, and John Newman as well, are sort of the godfathers of our program for pulmonary hypertension. And then Lisa Wheeler has been with them for many years, longer than I've been with the program by far, studying individuals who have pulmonary hypertension, getting to know families and whatnot. And so Lisa knows most of the families in the United States, I would bet, who have pulmonary hypertension. I'm sure there's a few here and there we don't know about. And our registry of individuals and families who have pulmonary arterial hypertension is really over 200 families that have pulmonary hypertension with two or more people in the family who have the disease. Really a lot of variability in those families. We have many small families that have only 2 people, but then we have some families that are larger that have 38 or 39 people. Some families with pulmonary arterial hypertension have it in multiple generations. So maybe a great-grandfather, then maybe no one in the next generation, but maybe that person's great-granddaughter or that person's granddaughter has it, and then maybe that person's daughter. So we'll track through the generations. Females, as Dr. Hemnes alluded to earlier, are about 2.5 times more likely to develop pulmonary arterial hypertension than males. Males certainly develop pulmonary hypertension. It's just that females appear to be more susceptible to developing the disease than males, particularly in families. And then there's this term incomplete penetrance, which I mentioned before. That is to say, there are many people in the families who have the disease who carry the disease risk. They're carriers of a gene that's a mutation, but they never develop disease. So it's incompletely penetrant in those people. And that can be difficult because sometimes families don't even realize they have pulmonary hypertension in their family because they have people who carry the mutation but never develop the disease. And so it can be tricky when it emerges. Our group, led by Elisa, Jim Lloyd, John Phillips, John Newman, some other people years ago now, about 14 years ago, first reported a gene mutation called BMPR2. BMPR2 is one of about 22,000 plus genes that we have in our body. So we have about 23,000 genes that are the building blocks of who we are. One of those genes is called BMPR2. It was discovered by Lisa and colleagues to be mutated, to be a gene mutation that associates very strongly with the development of pulmonary hypertension in families. Not every family who has pulmonary hypertension has a BMPR2 gene mutation, but about 80% of them do. Mutations, therefore, are the same in every family. So you can have a very small family or a very large family with pulmonary hypertension. They virtually all share the same, or they will all share the same mutation in that family. But we also know that there's many different mutations, so not every family has the same mutation. In fact, more likely than not, families do not have the same mutation. And if they have the same mutation, we begin to get suspicious that maybe those families are actually linked farther back in time than we realize. There are about 400 mutations that are described so far, and as we mentioned, about 80% of families who have pulmonary arterial hypertension in the family have a BMPR2 gene mutation. Interestingly, from a medical and research perspective, but sort of alarming from a life perspective for the population, is that actually about 20% of individuals who think that they have idiopathic or sporadic pulmonary arterial hypertension, that is to say they have no known family history, they have no known family reason to think that pulmonary hypertension is in their family, they actually have a genetic cause, and that genetic cause is a BMPR2 gene mutation. So it's a much lower percentage of the people who have no family history, but some people with no family history actually have pulmonary hypertension because they just didn't know they had a family history, and that family history is a BMPR2 gene mutation, which gets passed through the generations from the mother or father. If you have idiopathic pulmonary arterial hypertension and you have a BMPR2 gene mutation, even though you have no family history, you have that term heritable pulmonary arterial hypertension because you can henceforth pass that pulmonary hypertension down through the family generations. So where do BMPR2 mutations stack up in terms of some of the more common types of pulmonary arterial hypertension? As you can see here, about 80% of families with pulmonary arterial hypertension actually have a BMPR2 gene mutation. So there are some families that clearly have a family history but don't have a BMPR2 gene mutation, and we're working hard to understand why those families have it. Idiopathic, I just mentioned to you 20%. If you look at the range, it's about 10 to 25%, but 20% is a reasonable thing to say. And then there's a small percentage of people with congenital heart disease who have pulmonary arterial hypertension due to a BMPR2 gene mutation, and then a small percentage of people who take appetite suppressants. You may remember Dr. Hemnes said earlier, we're not really crazy about people taking appetite suppressants or diet drugs because those can actually potentially cause pulmonary arterial hypertension. HIV and scleroderma, which have been associated with pulmonary arterial hypertension as causes of it, have not been known to have BMPR2 gene mutations. So a mutation provides the predisposition, as you can see, for someone to get pulmonary arterial hypertension. But it appears that something else has to happen in most families, because I mentioned to you there are people who carry the mutation but never get the disease, and there are people who carry the mutation and become patients. So why would people have the same mutation but not both get the disease? We don't really exactly know. We're working extremely hard, and we think we were making a lot of progress on that cause, but we don't know for sure why some people get the disease and some people don't. That's that concept of incomplete penetrance again. So the mutation does not always cause disease in every person, so there must be other factors besides the mutation to cause it. The BMPR2 gene mutations, we think, are important for helping to release our good control on cell growth, so that sometimes, almost like a cancer, but it's not a cancer. I want to be clear about this, it's not a cancer, but there are some cancer-like features to pulmonary arterial hypertension in the sense of the gene's mutation somehow appears to cause an inappropriate control of growth of some certain types of cells in the lung that then cause the obstruction to blood flow in the lung circulation that ultimately causes pulmonary hypertension. It's not a cancer, but that gives us some clues of how to think about how we could treat it and, like Dr. Hemnes said earlier, cure the disease. BMPR2 is a really important gene for fetal development as well, and thankfully, as far as we know, people who have BMPR2 gene mutations don't have other major anomalies or variations in who they are. It's just the lung vasculature that is abnormal. So let's talk a tiny bit more about this notion of people who carry the mutation but are healthy and people who have the mutation and are patients. If you're healthy but you have the mutation, we're going to call you a carrier, and we're going to talk about this notion that you have incomplete penetrance. The disease never develops despite your genetic risk. So many family members are known to carry a mutation but never develop symptoms, as we said before. There must be other factors, as I mentioned a few minutes ago. So what other factors might there be that we need to discover so we can treat the disease better, we can prevent people from getting the disease? Well, there may be other genetic factors that are occurring that we just need to measure and figure out what they are. There may be other exposures, like maybe people take a drug or a toxin. We showed the appetite suppressant. Sometimes people have appetite suppressants, have BMPR2 gene mutations, and develop pulmonary arterial hypertension. Maybe there's something to do with being female, because I mentioned to you about 2.5 females for every 1 male are diagnosed with pulmonary arterial hypertension in families, or that's heritable. So maybe being female. So what's different about being female? It may be your hormones versus males, or it could be your genetic makeup. Males and females, males are XX on their chromosomes, X on their sex chromosomes, or XY on their sex chromosomes. Females are XX. So maybe there's something about having an extra X chromosome that is causing it. Maybe there's some other cause, like people get infections that cause a virus to make the BMPR2 gene mutation more important, so that unfortunately people get pulmonary hypertension. We don't entirely know about the infection angle, but it's something people have talked about before. I mentioned to you that 80% of families who have pulmonary arterial hypertension in families have a BMPR2 gene mutation. But what about those other 20%? And we've worked really hard lately. Lisa and I and Dr. Hemnes and colleagues, Dr. Lloyd and others have worked hard to try and figure out what other genes may be responsible, thinking, oh, well, maybe those are genes that could be important to all types of pulmonary arterial hypertension, including familial pulmonary hypertension, and maybe they could help to explain why we have this incomplete penetrance phenomenon. So we've recently discovered some other genes. We and other groups, we're not solely responsible for this by any means. SMAD9, which is another gene that's related to BMPR2, so it kind of makes sense that that might be mutated and cause disease in some small numbers of families. Caveolin-1 or CAV1 is written there. KCNK3, ALK1 or endoglin. I don't think we have any families here, but there are people who have a disease called hereditary hemorrhagic telangiectasia, or HHT. Those people have a gene mutation in ALK1 or endoglin, and they get disease. And then we recently participated in a multinational study, a national study that was also multinational, to show that 2 other types of pulmonary hypertension that are more rare, that I don't think anyone in this room has been challenged with, also have. And there's a gene called EIF2AK4 that's been associated with the gene mutation in those people. So there are other genes that we've discovered in the last 5 years. We're just not exactly sure how they all come together yet. So a few things that we wanted to talk about now, and I'm going to pass the mic on to Lisa, who's going to lead us through this aspect of the discussion.
First of all, Eric gave me way too much credit for being involved in all those discoveries. I am not the scientist. I am the administrator. But I appreciate it. So I'm going to talk a little bit about, a lot of you are involved in our research, so I know you have lots of questions sometimes about what happens with your samples and why you don't get results and that sort of thing. So we're going to go through that. And also, if you want to be, if somebody in your family wants to be tested to see if they carry a BMPR2 mutation, how do you go about that? What is that process? So a lot of people say, it's like, I gave you a sample already. Why do I have to do this again? So there's a difference between research testing and clinical testing. And one of the major differences is quality control. A clinical laboratory in your hospital or a clinic that you go to for your regular care at Vanderbilt, there's a huge clinical laboratory. You guys get blood drawn every time you come to clinic. That goes to the clinical lab, and your doctor, and you get that result back, and your insurance pays for it. That laboratory is overseen by many, 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 many regulatory agencies, so there's a high level of quality control. A research laboratory is not overseen by anybody except the researchers. And while we try to do a really excellent job, we're not perfect, and errors can happen. And so we just don't want anybody to rely on just a research result. The other issue is, by law, we're not allowed to give out results. There is a law called the Clinical Laboratory Improvement Act, came out many years ago, but it only allows clinical laboratories that are approved to release results. So that is one of the major reasons why we can't give you results from your research sample individually. So a simple rule for you to think of to help you just think through this on a very basic level is, did I pay for that test? Did my insurance company pay for that? If they did, or you did, then you get your result. If you volunteered to sample for research that you didn't pay for, then most likely in any research study, not just at Vanderbilt or not just with pulmonary hypertension, you will not get a direct result from that. So then the question is about clinical testing. Why do I have to give another sample? Well, what if the sample that you gave for research came to our lab, or at one time those samples came to a laboratory that collected samples from many studies, many researchers around Vanderbilt, and somehow they got that mixed up. Well, you wouldn't want that sample to go to the clinical lab to be tested because it might be the wrong sample. So the clinical laboratory is always going to ask for a new sample. And so now, how does this process work? If you or somebody in your family wanted to be tested to see if they carried a BMPR2 mutation, the first step would be to seek an appointment with a genetic counselor. And I put up a couple websites. The nsgc.org is the National Society of Genetic Counselors. On their website, they list every genetic counselor in every state in the entire country. So say you have, a sibling that lives in Washington State and they want to be tested, then we can go to that website and find out the genetic counselors there, give that information to them, then they can seek an appointment with a genetic counselor. So the counselors work with medical doctors that are geneticists. They would order the testing. Usually it's a single tube of blood that goes out to, and they would send it out to a laboratory that does testing for BMPR2, because not every lab at every hospital does that test. There's about 10 that I know of around the country that offer that test. So they draw the new sample, it gets sent to the testing lab, the result comes back to that counselor, and that geneticist. They would contact that family member to come in for a follow-up appointment and talk over the result with them. They'll talk about the risks of learning this information and the benefits of learning that information. And then just to give an example of a scenario that might come up. So a worried young lady calls and she says, my father died with this disease, and my aunt was just diagnosed, and now I have another aunt that has PH, and I'm worried that this could truly be my family, and here I am, I'm 32 years old, and I have a son, and what should I do? So in this case, the best option is always to test first somebody who is affected, because we know that they have if they're going to have a BMPR2 mutation, that is the person to test. So it would be best to have the surviving aunt of this lady to be tested to see if she carries a BMPR2 mutation. Once that's identified, then anybody else in the family that's at risk, that's in the bloodline, could be tested for that particular mutation. There's an advantage to that because usually it is less expensive if the laboratory only needs to test for a specific mutation rather than screening the entire gene. So it can be a cost benefit to that person, plus they know exactly what to look for. Other options, if they did not want to go the genetic testing route, would be for this individual and her child to be screened with usually echo ECG every 1 to 3 years. The World Health Organization recommendation for people who are at risk in families is every 3 years to have an echocardiographic screening. Right now, that's the best non-invasive tool we have. As you've heard, in some cases, it's not perfect, but at least if you have it done with some frequency, they're likely to catch something. Not every physician that takes care of pulmonary hypertension patients feels that this is necessary. So it's really kind of, I think, your own personal decision, how often you would want to be tested or if at all. And as I mentioned before, for testing, for genetic testing, it would be ideal to start with a person who's already affected. So what is the genetic counselor going to discuss? Mostly they're going to talk about what are the risks and benefits of learning this information for you personally. Could it be, your own life planning, family planning? I want to have a child, but I don't want to have a child if I have the mutation. Or, I want to have better screening if I have the mutation so I could get early treatment if it turned out I did have this disease. What are some of the risks? Oftentimes there's emotional issues because sometimes either result can be difficult. If it's positive, well, now I've got to worry about if I'm ever going to get this disease. And if it's negative, a lot of people have what's known as survivor's guilt. It's like, oh gosh, my mom and my 2 siblings had this, and but I've been spared, and why me? Why was I spared? So, and this is a true phenomenon. A lot of people do have this problem. You can also have potential problems with life insurance and disability insurance if you're found to have a mutation. And also, there's a cost. There's a financial burden to having this testing done. It's not cheap. So to talk about some of the other insurance issues. In 2008, there was an act called the Genetic Information Non-Discrimination Act that will protect anyone who gets genetic testing and ends up with a result that could predispose them to some sort of a disease. They cannot be discriminated against on health insurance, so your health insurance cannot get more expensive and it cannot be taken away from you. And you cannot be discriminated against in your employment, so you cannot be fired if you're found to have some predisposition to some sort of disease. Unfortunately, when they wrote this bill, they did not cover disability and life insurance. I don't know if at some point in time they will come up with a new bill or amend this bill to include those, but at this moment in time, it is not covered. So what is your individual risk if you're in a family that is, where somebody is a BMPR2 carrier? So we're looking at the dad over here, and I'm going to take this. These are very simple schematics of a gene. The dad is the carrier. He's got this. The green is going to represent the quote-unquote bad gene. The orange ones are just your normal healthy gene. So every child has a 50% risk of inheriting the bad gene. It's a little green one. And they'll always get a normal gene from the mom in this case. It could be the other way around. It doesn't matter. So, and then you have a 50% risk of inheriting normal genes from both your parents. So if you have a parent who is a carrier, every child they have has a 50% risk of inheriting the bad gene. But fear not. So what is your individual risk in a BMPR2 family? So your risk is 50% to inherit, but only approximately 20% of carriers ever develop symptoms. And there's a little caveat to that in a second. So I decided to get the genetic test, and I'm negative. Hooray, my risk is the same as it is of anybody else sitting in this room who is not in a family, 1 in 500,000. But if I'm positive, my risk is 1 in 5. There is also an issue, we were talking about women get this disease more often than men. So women actually have a higher risk. If you're a carrier for women, it's about 40% risk of developing symptoms in your lifetime. For men, it's about 15%. So that 20% is slightly deceiving. That's just if you look at the total population, men and women together. So that is the end of my talk, basically on the genetics. And a lot of people want to know what other things are we doing as far as research goes. And I know that most of you are on our mailing list, and you get our updates every 6 months that we send out about our research projects. But one of the big issues that we just discussed today is, why do females have a greater risk of developing pulmonary arterial hypertension? So Dr. Austin actually is doing a big study on really sex hormones in general, and how they influence development of pulmonary arterial hypertension. And if they do turn out, which we believe they will be, to be important, is there some kind of treatment that we could give that makes people push them to the better estrogens, and will that help people? It may not prevent the disease, but will it help with the treatment? And other things people ask about are, does PAH only ever affect our lungs? And you got to think about it. We know that obviously it affects the little blood vessels in the lungs, but it's a genetic change. So you would think that that's going to cause more than just a change in these little tiny blood vessels in your lungs. And so many researchers, including Dr. Hemnes and some of the other researchers at Vanderbilt, but also outside of Vanderbilt, have been looking more at the systemic effects of pulmonary arterial hypertension. What other systems does it affect? And we have found that it does seem to affect how people break down sugars. So in your food, you break down sugar to make energy. A lot of people with pulmonary arterial hypertension don't have a normal breakdown of their sugars, and also the same thing with your fats that you take in. So those are called lipids in the science world. So it looks like a lot of people with pulmonary arterial hypertension don't have normal breakdown of their sugars and their fats. And so we're trying to understand, what does that mean as far as your symptoms? Does that give us a clue to a treatment, a different place where we could apply different treatments? And also, we're looking at, why do BMPR2 mutations cause PAH? And obviously, we've been looking at that for a very long time. We do have some good clues, and so we're looking at ways, if we understand that pathway, are there places in that pathway where we could come up with a treatment that would stop the progression of the disease, or maybe prevent it? Would be great. And then, obviously, that Dr. Austin alluded to, we're looking at other genes that we have been found that cause the disease, and do they give us clues to pathways that are affected, chemical pathways in your body that are affected, and could that give us some ideas of better treatment options? And then we are doing, as many of you are involved in those, long-term pulmonary arterial hypertension carrier studies, and also just in families. Some of you have been, or your families have been involved in this study for more than 30 years. I've been involved for 20. But it has given us, that long-term follow-up has given us some very important insights into this disease. So your family involvement has been very, very, very valuable. And it's taught us a lot of things, and so we appreciate the fact that people have been involved and are willing to be involved for such a long period of time. I know there's 2 families represented here today, and both of your families have been involved in this study since Dr. Lloyd started in 1979. So that's pretty impressive. So anyway, questions? Please, somebody has to have a question.
Does this make sense, the notion that you have people who have the disease, risk that they never get the disease, and then you have people who have the risk, in this case, the risk is the gene, there are two gene mutations are most common, but you never get it, you do or don't get the disease. And one of the things that Lisa just mentioned and we're so interested in is figuring out why is that, and if we can ultimately figure that out, can we not only treat the people who have the disease, could we one day take the people who are healthy but at risk and give them some sort of simple medicine or simple agent of some sort
No, prevent
prevent
it.
it from ever happening? Wouldn't that be awesome? Because we really don't know if someone has a mutation and they're healthy, we don't know, are they really totally normal and we're just fortunate, or do they have below the threshold of what we understand as abnormal and normal is, and just someday going to get the disease? So do we help keep healthy people healthy?
Right, right. Because most researchers and physicians who treat the disease believe that you have a great deal of damage to the vessels in your lungs long before you've developed symptoms. I mean, our bodies are just amazing at compensating. You can go a long way and lose a lot of your, what we call your vascular bed. So all those little blood vessels that are around those alveoli that Dr. Hemnes showed you earlier. Many, I think that you could probably lose half of those before you develop symptoms. So there may be people who are carriers that are losing those, and they still may never get disease in their normal lifetime, but I'll get you. But they might, and so if there's some way we could learn, some medicine we could come up with that would stop that process, that would be great, and that's what we're aiming towards. Yes, sir.
I'm asking a question for my nephew. He had
Yes.
on the age limit of the children from from Robert Bellamy. Where should they be, tested? What was the age limit?
Well, the disease can occur at any age, from infancy to elderly. I think I may turn this over to Dr. Austin since he takes care of pediatric patients.
So I think the question is, when should we test a person?
The children, the offspring, when would the age basically or minimum age?
It's a great question. So we've taken, as Lisa mentioned, the international guideline from people who are experts internationally has been every 3 years to get an echocardiogram and an electrocardiogram screening regardless of age. So if you have a 1-year-old, you would consider doing it. Now, the honest truth is, it's a little hard to get an echo sometime that's informative in a feisty 18-month-old, so you have to use some degree of judgment. But I've taken the tact in our families, and we've talked about this, some of our families, we've talked about this, is I like the notion of screening everyone when we first have a new diagnosis in the family, and then screening them every 1 to 3 years depending on the preference of the family. Thankfully, the vast majority of people will not be diagnosed during childhood, but we know that there are people who are diagnosed during childhood, so we try and be careful about that and not blow it off and wait till they're 18, if that makes sense, because we do know there are people who do develop the disease when they're young. And so I also see benefit in screening the young children because to a certain extent they may have more insurance opportunities before age 18 than people will who are after age 18. The other thing to think about that comes into what Lisa alluded to is the notion of genetic testing. Genetic testing with proper guidance from a counselor and absolute understanding on behalf of the family and you can be helpful in some of those circumstances, because if you think about it from straight finances, an echocardiogram every 1 to 3 years is going to be about $1,500 charge to your insurance, maybe a little bit more depending on their contracts. It's not all about the money by any means, and that's the least important thing in my mind. I just want the people to be healthy. But families have to deal with the burdens of these testings, and so it's a big deal. And so if you have a family-level mutation, so say there's a mutation in your family, sir, that you know about, you may want to I know it's your nephew, I think. So he and his family your family might want to talk and think about, well, do we want to consider testing the children for the mutation if we know the mutation in the family? Because while that may be a little bit more expensive up front, that would save many years of anguish and many years of cost of echo screening. The flip side to that is if the echocardiogram is, if the mutation testing shows that those children have the mutation, well, then they go into Lisa's, I love her picture here, they go into this category, and you haven't helped them that much. You just know now they have about a 1 in 5% chance instead of a 1 in 10. Does that make sense? So if they're negative by the test, woohoo, it's basically the risk of me, which I'm blessed to have a very low risk. But if they're positive, it didn't really shift the curve that much. So I like to talk about genetic testing for the family members also and let them decide that for themselves. The other discussion about the genetic testing that's complicated that Lisa also nicely showed is this notion of, are you suddenly giving a kid a label for the rest of their life with regard to insurance, insurability and other things? Now, the reality of it is, it may be such an overwhelming part of your family's life that there's still going to be risk anyway, because they're going to tell their insurer, your insurer is going to say, what family diseases do you have? And you're going to have to decide, am I going to tell them that my mother had pulmonary hypertension in the family or not? Yeah. So you don't necessarily have to you're obligated to be ethical when people come to talk to you. But if you get genetic testing for an individual in one of these approved labs, which would be the appropriate way to do it, that's that CLIA, that CLIA term that Lisa said earlier, those labs input that information into the individual's medical record. So your child will have that in their medical record. Yeah, exactly. But on the flip side, you could make the argument, well, they're also, if they told them that my mother has familial pulmonary arterial hypertension, they'll know, if they're at all savvy, that that person has a 1 in 10 risk of developing the disease themselves. So it's sort of a balance. It's a long-winded question to say, if you were going to ask me if I've got 2 kids in a family and they may have familial pulmonary hypertension, I would start by getting them an echo every 1 to 3 years, regardless of their age. Or consider genetic testing as part of that as well.
The other point, too, would be if the child started developing any kind of concerning symptoms. A parent knows their child the best. If suddenly their child can't keep up with their peers, that where they were at the front of the pack, and then all of a sudden they're lagging way behind in their activity level, then that might be very concerning. And so that would definitely be a cue to come and maybe have that child screened. I'll just give an example. We had a family who had a 13-year-old, and he'd been having some symptoms, but they weren't positive that it was pulmonary hypertension. But he had concerning symptoms, but the family did not want that child to be put through a right heart catheterization unnecessarily. So they wanted genetic testing for that child, and they did go ahead and get genetic testing on the advice of their cardiologist, who was getting ready to do the right heart catheterization. So they were very careful. They talked to their doctor, they talked to a genetic counselor, they did pursue the testing. Obviously, since I'm not involved in that child's care, I don't know what the results were, but so it is something that needs to be carefully thought out with the child's physician and a genetic counselor and geneticist. But certainly if a child was showing any kind of symptoms, it might be worth at least getting the screening echo, if not genetic testing.
And we're happy to see individuals at Vanderbilt, the children, and talk to the families and spend that time with them if that would be helpful.
It's no secret. The one that I'm referring to is Robert Bellamy's Leo's. It's got the 3 children. So
Yeah.
Y'all know all about it.
Yes.
It's right here, but he was supposed to be, but he didn't. Billy's brother,
Had a time conflict.
Right.
Family conflict.
We're happy to talk on the phone. We're happy to see those kids for echo.
Right.
I would suggest one other thing is that if they do get an echo, have it done in a pulmonary hypertension center, because the echocardiogram is hard enough to interpret for the pulmonary hypertension aspects. for those of us who are fortunate to be in centers that do it all the time. And so I would say if you're gonna go the echo route, talk to us and we'll help either bring you to us or send you, if you prefer to go somewhere else, that's totally fine. But just, I would say go to a center that's comfortable getting pulmonary hypertension echoes.
Any other questions? Yes.
If you're a carrier,
Mm-hmm.
is it good to go ahead and have the echo and those tests done every 1 to 3 years?
Well, it depends on who you talk to.
Johnny did have it done
Yeah.
right after Jimmy died.
Yeah, it probably, I'm not a physician, so I really don't feel comfortable giving you that advice. I would say it's more your personal comfort level. If it gives you relief to have that screening done, then I think it's very valuable.
Well, to me, it's valuable, but to Johnny, he thinks that he didn't have to have it.
I would just, so I really can't offer you, I can just tell you what, is recommended. I can't offer you something on a personal level, but I would just say some physicians would say, it may not be necessary, but certainly if you developed any kind of symptoms that were suspicious at all, definitely seek if physicians consult immediately.
And one other question. Whenever, like Johnny is the carrier, and if our children doesn't have them, is that where it stops, or the next generation with their children?
If your children had genetic testing and they were negative, then their children are going to be negative. I mean, they can't pass along something they don't have. If they were positive, then yes, they could potentially pass it along to their children. Mm-hmm. Sure. Anything else?
We're happy to linger.
Yes, we'll be happy to answer any other questions. And thank you guys so much for coming, and I hope it was helpful. And be safe going home.